I will discuss the questions of surgery in CBT. So we'll discuss the first question of surgery. The normal level of PSA in male. See, this PSA is prostate specific antigen. This prostate specific antigen is actually a glycoprotein. This is a glycoprotein which helps in liquefaction of semen. So this was one question. What is the role of PSA? Role of PSA is it helps in liquefaction of semen. The normal values it is between 0 to 4, we can say nanogram per ml. So less than 4 nanogram per ml is the normal value. So this is our answer. See, between 4 to 10, if the value is between 4 to 10, this can be seen in BPH, it could be malignancy, or it could be prostatitis. So 4 to 10, it could be any of these things, any disease related to prostate. So we can say this is organ specific, not disease specific. It could be BPH, carcinoma, prostatitis. But if the value is more than 10, mostly it is due to malignancy. Mostly malignancy. And if it is more than 20, we can say metastatic malignancy, disseminated metastatic cancer. So this is the significance of PSA. If the PSA is very high, then it is mostly a malignancy. 4 to 10, it could be anything. Now apart from this, there is something known as PSA density. PSA density. PSA density is PSA divided by prostatic volume. If this PSA density is more than 0.15, then it is probably malignancy. So this is an indication for biopsy. Biopsy to rule out malignancy. And we know biopsy, when we do biopsy in case of prostate, it is better to go under transrectal ultrasound guided biopsy. So this is PSA density. More than 0.15, biopsy. Another important thing about PSA is PSA velocity. That is, what is the rate at which PSA is increasing like every year. So if it is more than 0.75 nanogram per year, again it signifies it is basically a marker towards malignancy. So again, you have to rule out malignancy by doing a biopsy. So that is the important thing about PSA, the normal values, what is PSA density and what is PSA velocity. In our question answer, the normal value will be less than 4 nanogram. Coming to the next question, a patient suffered from 3rd degree burn of right upper limb. See, in this question, the most important thing is 1st degree burn is not included when you calculate the total body surface area burn. It's not included in total body surface area burn. So 1st degree burn you will not include. So 3rd degree burn of right upper limb means 9%. 2nd degree burn of right lower limb 18%. So it comes out to be 27%. So answer here is 27%. So if we calculate by rule of 9, we all know rule of 9, Wallace, Alexander Wallace rule of 9. 9% each for upper limb, 18% each for lower limb, 18% for the front of trunk, 18% for the back of trunk, 18% for the head and neck area, and 1% for the perineum. So according to this, in our patient, this is a scenario. 1st degree burn of whole back, we will not include 1st degree burn. So that's why 9 plus 18, it comes out to 27%. For small patchy burn, palm of the patient is approximately equal to 1%. So palm is 1%. So this is rule of 9 in case of burn. In case of children, slightly different. 14% here. Okay, sorry, this is 9% in adults and 18% in children. So in children 18%, adults 9%, 14 in case of children. So this is the only difference. This is the difference. 14% for lower limb, 18% for head and neck in case of child. That is the difference. Perineum is not included in the pediatric population, so we can say perineum area we will not include in case of adults. We will give 1% to the perineum. So according to this rule of 9, it comes out to be 27. In the adults, head area is 9%. In children, it is 18%. So this was a simple question. The only thing you need to, rule of 9 you all know. Just remember, first degree burn you will not take into consideration when you calculate the total body surface area burn. Stain used to diagnose pre-malignant lesion of lip. See, pre-malignant lesion of lip, we can say pre-malignant lesion of oral cavity can be diagnosed by some stains. These stains are known as supravital stains. Stains for pre-malignant lesion. You can say there are few stains like vital iodine stain. When you stain the lesion, suspicious lesion with vital iodine stain, the normal mucosa will be stained and the abnormal will not be stained. So that is vital iodine. It will stain the normal area, stain the normal mucosa. So that part of the mucosa which is not stained, that is suspicious. Toluidine blue, which is our answer here. Then nowadays they use chemiluminescence. Chemiluminescence use peroxide with acetyl salicylic acid for staining. Chemiluminescence. Now light emission technique. So these are some of the techniques which is used to stain the suspicious area, pre-malignant lesions like leukoplakia, erythroplakia. So these basically they will stain the mitotic figures, mitotic index. So in this our answer is toluidine blue. Toluidine blue is the answer. The pre-malignant condition with the highest probability of progression to malignancy. Highest probability is seen in erythroplakia. Erythroplakia is, this is red velvety, we can say, lesion on the oral cavity. This has 17 times increased chances of, we can say, developing into malignancy. So this is a pre-malignant lesion, erythroplakia. Mostly this is present on the, we can say, palate. Palate is the most common site. Leukoplakia is also pre-malignant. We can say the highest nodular or speckled type of leukoplakia has high risk of developing into malignancy. See, all cases of leukoplakia does not require biopsy, does not require treatment. If you find a whitish patch, if the patient is smoker, ask the patient to stop smoking. Most of the time the leukoplakia disappears. But in case of erythroplakia, it might disappear, it might not disappear. So erythroplakia has very high chances of developing into malignancy as compared to leukoplakia. So remember, all cases of leukoplakia does not require, I mean all cases of these white patches does not require a biopsy, but erythroplakia requires biopsy to rule out the malignant changes in it. So in this, erythroplakia is the answer. Structure damage most commonly during surgery of ranula. See, ranula, first of all, there is very controversy about ranula, that what is ranula basically. So ranula, this is, just remember, ranula is a mucus extravasation cyst in relation to the sublingual gland. So this is clear, ranula is mucus extravasation cyst. There is one more type of ranula that is known as plunging ranula. If they are asking question about plunging ranula, then this is mucus retention cyst in relation to sublingual as well as submandibular gland. So this, just remember, ranula is mucus extravasation, plunging ranula is mucus retention cyst. Now, in case of ranula, when we do surgery, treatment options is, one is simple aspiration. Aspiration, there is very, very high risk of recurrence. So you will not just aspirate, you have to do the surgery, that is surgical excision. Intraoral excision you do. Intraoral excision surgically. In case of large ranula, you can go for marsupialization to prevent the risk of recurrence. Plunging ranula, the treatment is, see, in case of ranula, you will go by the intraoral approach. In plunging ranula, the treatment is surgical excision with removal of submandibular and sublingual gland. So in that case, you have to remove submandibular plus sublingual gland. In simple ranula, you may or may not remove the sublingual gland, but submandibular is not removed in simple ranula. But in case of plunging ranula, you have to remove the ranula swelling as well as submandibular and sublingual gland completely. And this is done by cervical excision. So you will give incision in the, we can say, submandibular region at the neck part, skin incision. In ranula treatment, skin incision is not given. You will go by the intraoral approach and remove the swelling. So that is important point in the cause as well as the treatment of ranula and plunging ranula. Now the complications which can occur in the ranula surgery, when you do surgery, recurrence is one complication. Sensory deficit. Sensory deficit occur because of there is damage to the labial branch of mental nerve. Labial branch of mental nerve can get damaged, so that can lead to sensory deficit. Injury or damage to Wharton's duct. Wharton's is, we know this is submandibular duct. Then hematoma, infection, these are other complications. So if you see in our question, they have asked about the complications of ranula surgery. Structure damage most commonly out of all these, submandibular duct is the answer, Wharton's duct. So this is the answer, submandibular duct. Lingual nerve is commonly damaged during surgery for submandibular duct stone. During surgery for submandibular duct stone, lingual nerve, there are high chances of damage to lingual nerve. Coming to the next question, which of the following gastrointestinal disorders predisposes to urolithiasis? Peutz-Jeghers syndrome is, there are multiple hamartomas, hamartomatous, polyp in the intestine, mainly in the jejunum. So this can lead to intussusception and intestinal obstruction. Familial polyposis coli, again adenomatous polyps. So this is a pre-malignant condition. This can lead to malignancy of colorectal cancer, then duodenal cancer, stomach cancer. So adenomatous polyp. Ulcerative colitis is again, there will not be urolithiasis in ulcerative colitis. There can be different intestinal as well as extraintestinal manifestations, but not urolithiasis. In case of short bowel syndrome, the complications which can occur is, first of all, the electrolyte and nutrient deficiency, increase chances of gallstone disease because of derangement of the, we can say, the enterohepatic circulation. So the bile salts are not absorbed from the terminal ileum because many a time terminal ileum is lost. So that is there. and there is hyperoxaluria. Hyperoxaluria, which will lead to nephrolithiasis or urolithiasis. So you can say out of all these, short bowel syndrome is our answer. Because of hyperoxaluria, this can lead to nephrolithiasis. The short bowel syndrome as such is an important topic because short bowel syndrome, if you go by definition, short bowel syndrome is, if we can say the length is small intestine length less than 200 centimeter. Small intestine less than 200 centimeter. And if there is absence of ileocecal wall, so if the ileocecal region is removed, absence of colon. So these are some of the, like, by definition, this is short bowel syndrome. The causes, mesenteric ischemia is the most common cause in adults. Crohn's disease is very common in the Western population. So in Western population, we can say Crohn's disease is the commonest cause. Otherwise, overall, in the world or in our region, in India, mesenteric ischemia leading to infarction of a large amount of bowel. Midgut volvulus, and we can say necrotizing enterocolitis. These are common causes in children. So in children, necrotizing enterocolitis, midgut volvulus. In adults, mesenteric ischemia, Crohn's. They are the common causes of short bowel syndrome. So if we see treatment options for short bowel syndrome, medical treatment is not very effective. We can say patient can be put on total parenteral nutrition, but TPN has its own complication. Many times the patient who is on short bowel syndrome, if you put the patient on total parenteral nutrition, there can be liver damage also. So most of the times these patients, they need small intestine as well as liver transplant. Surgical options, there are surgical options like longitudinal intestinal lengthening and tapering, then sequential transverse enteroplasty. So these are, we can say, intestinal lengthening procedures. Can be tried, not very successful. The best option for short bowel syndrome is intestinal transplant. So intestinal transplant is the best hope for these patients. TPN has its own complication. We can put the patient on TPN for a short term, but not lifelong. So in our question, urolithiasis is a complication, a well-known complication of short bowel syndrome. Coming to the next question. What is the most important aspect of management in burn injury in the first 24 hours? So in first 24 hours, the most important thing is, the most important cause of death is hypovolemic shock. So you have to prevent hypovolemic shock by fluid resuscitation. Fluid resuscitation is the most important thing in the initial 24 hours. This is our answer. Because in the initial 24 hours, there is fluid shift, the fluid shift from the intravascular space to the extracellular space. That's why there is hypovolemia. So if we see IV fluid is required for patient if there is more than 15% total body surface area burn in case of adults and more than 10% total body surface area burn in case of children. If the burn is less than this, then you can provide first aid to the patient, you can discharge the patient, you can ask the patient to take plenty of fluids. So there is no need of admission basically. But if the burn is more than this, then patient needs admission and patient needs intravenous fluid therapy. And the fluid of choice will be a crystalloid. Initially, crystalloids are preferred. This crystalloid is either a Ringer lactate or Hartmann solution. Ringer's lactate or Hartmann solution for the fluid resuscitation. The initial period, we know the amount is calculated by most commonly by Parkland formula. There are other formulas also, but this is a universal formula most commonly used. So total amount in milliliter for first 24 hours is equal to 4 into weight of the patient in kilogram into percentage of total body surface area burned. This is the Parkland formula. There is one important thing about this is this percentage total body surface area burned, maximum you will take here is 50. So even if the patient, the burn is 60%, 70% or 80%, here you will take 50 is the maximum. Out of this total, half in initial 8 hours and remaining half in next 16 hours. So this is a fluid resuscitation you will give in case of burn patient. So the most important thing is fluid resuscitation. Initially, you prevent the patient from going into hypovolemic shock. Later on, you will prevent the septic shock by the dressings and the antibiotics, or if you want any, if you need, the patient needs, you can do surgeries also. But initially, fluid resuscitation is the most important thing. So that is our answer, fluid resuscitation, option number A. Coming to the next question, a man who had undergone total gastrectomy remains well for 5 years, then he develops anemia. What is the most likely cause of his anemia? See, there are metabolic complications associated with gastrectomy. Metabolic complications. So the most common cause of, if you say anemia in a post-gastrectomy patient, what is the most common cause? Iron deficiency. Iron deficiency anemia is, we can say, most common cause. There can be vitamin B12 deficiency also, especially if there is total gastrectomy, because this intrinsic factor is released from the parietal epithelium, parietal cells, and these parietal cells are mainly present in the fundus and body. So total gastrectomy or in the proximal gastrectomy, vitamin B12 deficiency occurs because of lack of intrinsic factor. In distal gastrectomy, vitamin B12 deficiency is rare because the proximal stomach, it will keep on secreting intrinsic factor, which is important for vitamin B12 absorption. Then osteoporosis can occur because of calcium deficiency. Fat absorption, fat and protein malabsorption can also occur, but not to a major extent. So after remains, he was fine for 5 years, then he develops anemia. So for initial 5 years, the vitamin B12 result, if you treat vitamin B12 deficiency, vitamin B12 results are there, then it will remain there for like 4-5 years. So after 5 years, if the patient is developing, we can say anemia, then it is because of vitamin B12 deficiency. If patient develops anemia in the within a year, within 6 months, then it is mainly because of iron deficiency. After 5 years, mostly because of vitamin B12 deficiency. So in this case, answer is vitamin B12 deficiency because of lack of intrinsic factor in total gastrectomy. Subtotal or distal gastrectomy, vitamin B12 deficiency is not that common. Now we'll go for next question. Patient with blunt abdominal trauma presented to casualty with hypotension and tachycardia. Investigation to be done. See, blunt trauma, abdomen. Investigation of choice if patient is hemodynamically stable. Hemodynamically stable means his pulse is, there should be no tachycardia, no hypotension, urine output is fine, no acidosis. That is hemodynamically stable. So if patient is hemodynamically stable, he can wait and you can go send the patient for CCT abdomen. CCT abdomen will tell the grading also. There are grading of like liver trauma, renal trauma, splenic trauma grading. So grading is given by CCT abdomen. So in any question, if they are giving grading, means patient was hemodynamically stable. That's why they had sent the patient for CCT, and during CCT grading was done. Patient is hemodynamically unstable. Unstable means tachycardia, hypotension, increased urine output or acidosis. If any of these things are there, patient is hemodynamically unstable. In our question, patient is hemodynamically unstable. In this case, the investigation of choice is FAST. FAST is focused assessment sonography in trauma. This is done by surgeon only. You will not send the patient anywhere in the radiology. This is done by surgeon. There are ultrasound machines in the casualties. You will put the ultrasound probe at these 4 places and you will see the presence of free fluid. So FAST basically tells free fluid in the peritoneal cavity. In case of trauma, free fluid means blood. So if free fluid is there, we will say FAST positive. If it is not there, we will say FAST negative. So FAST report comes only FAST positive or negative. They will not see in detail whether there is liver injury or spleen injury, renal injury. They will just tell you that there is presence of free fluid in the abdominal cavity or not. And this free fluid should be minimum 200 ml for the FAST to become positive. So if FAST is positive, means there is at least 200 ml of free fluid in the peritoneal cavity. Then only the patient, we can say he is FAST positive. If FAST is not in the option, the nowadays DPL is not done, we can say the best thing, the next best thing is operate the patient, laparotomy in the OT. If FAST is not in option, next best thing is explore the patient in the operation theater. That is the next best thing you can do. So in our question, hemodynamically unstable, FAST is to be done. MRI has no role. CT in case of stable. DPL was one of the procedure. Nowadays, because FAST is there, so DPL is not used. Complications of chronic pancreatitis include the following except. See, in this question, they are asking about chronic pancreatitis, not acute pancreatitis. So complications of chronic pancreatitis, if we see, pseudocyst. Pseudocysts are very commonly, we can say the most common cause of pseudocyst is chronic pancreatitis. Biliary obstruction because of the fibrosis, especially if it is in the head region of the pancreas, then this will lead to biliary obstruction, so obstructive jaundice can occur. Gastric outlet obstruction because of the fibrosis, adenocarcinoma of pancreas, pancreatic ascites, pleural effusion, splenic vein thrombosis. If there is splenic vein thrombosis, then this can lead to portal hypertension. This is known as left-sided or sinistral portal hypertension. So this will be seen, obstructive jaundice will be seen, duodenal obstruction will be seen, renal artery aneurysm is not a complication. So this is our answer. Except they have asked except, so except renal artery aneurysm, duodenal obstruction because of fibrosis, obstructive jaundice because of fibrosis of the common bile duct, portal hypertension because of splenic vein thrombosis. So these are the complications. Renal artery aneurysm is not a complication. In case of acute pancreatitis, there can be splenic artery aneurysm, gastroduodenal artery aneurysm. Renal artery aneurysm is rare in case of acute pancreatitis also. So, but remotely it can occur, but not in case of chronic pancreatitis. So in chronic pancreatitis, renal artery aneurysm is not seen. Rest of the options are seen in chronic pancreatitis complications. In which of the following condition gas under diaphragm is not seen? So gas under diaphragm is basically the most common cause is pneumoperitoneum. Pneumoperitoneum, which is mainly because of perforation of hollow viscus. Perforation of hollow viscus. So perforated duodenal ulcer, it will be seen. Typhoid perforation, it will be seen. After laparotomy, it will be seen. See, perforation of hollow viscus. One cause of pneumoperitoneum or gas under diaphragm is Chilaiditi syndrome, in which the colon comes between the diaphragm and the liver. So if you take the X-ray, you will find gas under diaphragm-like picture. Subdiaphragmatic abscess, which is caused by gas-forming organism. Post-laparotomy or post-hysteroscopy. Spontaneous rupture of the esophagus is our answer, because spontaneous rupture of the esophagus is basically, that is Boerhaave syndrome, that is mainly occurs in the thorax. This is the site of spontaneous rupture. So in this case, gas will go in the mediastinum, that will cause pneumomediastinum. So spontaneous rupture of esophagus will not lead to pneumoperitoneum, it will lead to pneumomediastinum. It will lead to pneumomediastinum, so hence this is our answer. The rest, all the options, you will find gas under diaphragm. Coming to next question, what is the best method to treat a large port wine hemangioma? These are capillary hemangiomas. Port wine is persistent. Mostly this will present at the time of birth and it will remain throughout the life. This will not disappear. The other types of hemangiomas, capillary hemangiomas like strawberry hemangiomas, stroke bite, those will disappear. But this type of capillary hemangioma, port wine, this will be persistent. This is capillary malformation. Most common site is, this is present mainly on the face. This is associated with few syndromes like Sturge-Weber syndrome and Klippel-Trenaunay syndrome. The gene responsible for this is GNAQ gene. Mutation in this gene can lead to port wine hemangioma. Treatment. We see the treatment options: surgery, radiation, tattooing are some options, but the best option for the treatment of this is pulsed dye laser. So lasers, pulsed dye laser is the best option for the treatment of this capillary hemangioma. This is port wine. So answer is D, pulsed dye laser. This is our answer. Other options are also, these are all treatment options. You can give radiotherapy, tattooing, excision, but the best out of these is pulsed dye laser. All the options are the treatment options, but the best is pulsed dye laser. Tube enterostomy is indicated when the enteral feeding is required for more than, see, enteral feeding is, in enteral feeding you are using the GI tract. So GI tract is used for, this is done for patients having functional GI tract. So if you don't want to give rest to GI tract, patient is having functional GI tract, but they cannot, but these patients, they can't take oral intake. I mean, oral intake is not good, orally enough. So that patient, they need enteral feeding, like prolonged anorexia, severe protein energy malnutrition, patients in coma, liver failure, head injury, burns. So these patients, the oral intake is not good, so you can use the enteral feeding. Enteral feeding is always better than TPN. If you compare enteral and TPN, then this is better. TPN you will use in those patients in which you want to give rest to GI tract, like in case of enterocutaneous fistula, short bowel syndrome. So there are other indications for TPN, but out of enteral and TPN, this is preferred because of the better preservation of the GI tract. The cost is also low, and the complications are also low in enteral feeding. So tube feeding is required if the patient, like tube enterostomy means, usually when you give enteral feeding, you will put a nasojejunal tube or nasogastric tube. Tube enterostomy means either a tube gastrostomy or a feeding jejunostomy. Tube gastrostomy or feeding jejunostomy, this is done if enteral feeding is required for more than 6 weeks. So if it is required for more than 6 weeks, then you will not give by nasojejunal route, you will use the either a gastrostomy or a feeding jejunostomy. So more than 6 weeks is our answer. Into question number 14. What is the most common complication of Meckel's diverticulum among adults? So Meckel's diverticulum, this is a congenital diverticula of the intestine, mainly from the antemesenteric border, 2 feet proximal to IC junction. Complication, so we can say most common complication. Many times it can be asymptomatic. The patient will never come to you if it is asymptomatic. Most common complication in case of adults is obstruction. This obstruction can be secondary to intussusception, or it can be due to volvulus because of the band. In case of children, the most common complication is bleeding. So mainly Meckel's diverticulum is seen in children. So if they don't ask specifically adults or children, then bleeding will be the most common complication. But in this case, they have asked specifically in adults. So you can say intestinal obstruction is the answer. Intestinal obstruction. In case of children or not specified, then answer will be bleeding. Coming to the next question. One side of the kidney is normal, the other side is contracted with scar. What is the most common? What is the most probable diagnosis? So contracted kidney with scar, there can be like, one is known as primary contracted kidney. Primary is because of the renal vascular damage. Renal vascular damage. Like in case of hypertension, atherosclerosis, infarction. But primary are usually rare. Primaries are rare. Secondary causes, secondary contracted kidney is common. This is because of inflammation or infection. So this is because of inflammation or infection, secondary contracted kidney. This is common, I mean more common than the primary. This is because of pyelonephritis, tuberculosis, nephrolithiasis, diabetes, glomerulonephritis. So these are the causes of secondary or the common type of contracted kidney. So if we come back to our question, what is the most probable out of these? Chronic pyelonephritis is the most common cause. Renal artery stenosis will lead to primary. Tuberculosis can also lead to secondary, but out of all these, chronic pyelonephritis is the most common cause of a scarred kidney. Moving to question number 16, regarding burst abdomen, which of the following condition carries high risk? See, burst abdomen is a condition when the intestine or omentum or other intra-abdominal viscera is seen from the abdominal wound, is seen through abdominal wound after surgery. This is usually occurs, we can say, between 5th to 7th post-op day. 5th to 7th post-op day is the usual time. There is one more question about this burst abdomen is, what is the telltale sign? We can say the characteristic sign of this is serosanguinous discharge. So serosanguinous discharge, we can say pink color discharge between 5th to 7th day, basically tells that the patient is going to have burst abdomen. very soon. So there are many things, the factors, patient factor, surgeon factor, technique factor, suture, closure. Nowadays, they say there should be mass closure. There is no need to separate the abdomen layer by layer. You just do the mass closure, that has less risk. Sutures, you should use, we can say non-absorbable, has less risk. Decreased risk if you are using non-absorbable suture. Decreased risk if you are doing a mass closure. Then incision. Midline incision has high risk. A paramedian or a transverse incision has low risk. Then other patient factors, like if there is increased intra-abdominal pressure, like vomiting, cough, constipation, obesity, distension, all those things, malignancy, the patient is having jaundice, diabetes, hypoproteinemia is very important, especially hypoalbuminemia. It is very important feature. Anemia, immunocompromised, so all those things which will lead to impaired wound healing will cause this also. In our option, high risk is there in the median incision. Interrupted suture, low risk. Non-absorbable, low risk. Transverse incision and paramedian has low risk. Median, that is the midline incision, has a high risk of a bust abdomen. Coming to next, all electrolyte abnormalities are seen in immediate post-op period except. See, there are electrolyte abnormalities can be seen in the immediate post-op period. Electrolyte imbalance occurs because of fluid therapy. Mainly because of fluid therapy, because most of the times you give, because in the immediate post-op period, this is a stress, surgery is a like stress to the body. So there will be negative nitrogen balance. Because of the renin-angiotensin system, hypokalemia will be seen, glucose intolerance will be seen, slight hyponatremia seen but not significant. So in case of, because of fluid therapy, if you give like dextrose, this is very commonly given, dextrose 5% is given. So you can say this dextrose 5%, it does not contain any sodium. So because of this, patient can go into hyponatremia. So hyponatremia can be seen because of this fluid therapy, not hypernatremia. So this is the most probable answer, because negative nitrogen balance is definitely seen, hypokalemia is seen, glucose intolerance is seen because of the resistance to the glucose, peripheral resistance will be occur, insulin intolerance we can say. Hypernatremia is not seen, instead of that hyponatremia is seen. Coming to next, which of the following is the most common cause of hypotension in lower rib fracture? See, lower rib fractures, like this case, you can say 10 to 12 ribs. On the right side, this will lead to liver injury. On the left side, this will lead to splenic injury. Usually hemoperitoneum, pneumoperitoneum, it can occur, but it is not very common. So you can say abdominal solid organ injury is the most common cause of hypotension in fracture of the lower ribs. In the upper ribs, it could cause pneumothorax, hemothorax, flail chest, contusion, but in the lower ribs, mainly it will cause abdominal solid viscera organ, which will lead to these complications. This hemoperitoneum, and hemoperitoneum will lead to hypotension. The following have strong relationship of H. pylori. See, this H. pylori infection can lead to chronic gastritis type B. It can lead to peptic ulcer disease, both duodenal ulcer and gastric ulcer. Can lead to adenocarcinoma of stomach. H. pylori infection is also a cause of Malt lymphoma. of stomach. So these things are there. You can say gastric adenoma is not usually related to H. pylori. Gastric adenoma can be seen in conditions like you can say familial adenomatous polyposis. Many times gastritis can lead to gastric adenoma. Chronic PPI can also lead to gastric adenoma. So this gastric adenoma is a pre-malignant lesion, but H. pylori infection, out of the given options, we can say gastric adenoma is not due to H. pylori. Rest all options, there is proven relationship with H. pylori infection. Coming to the next question. Question number 20. The treatment of cholecystoenteric fistula following ulceration of gallstone through the gallbladder into the duodenum. See, cholecystoenteric fistula, if you see the most common site, cholecysto means gallbladder, with enteric means the most commonly it is first part of duodenum. This is one question. What is the most common site? It is first part of duodenum. And the second most common site is transverse colon. So these are the sites in which because of the chronic pressure by the stone, there will be necrosis of the wall of the gallbladder as well as of the intestine, and the stone, there will be formation of fistula between the gallbladder and the intestine. And this can lead to gallstone ileus. It can lead to gallstone ileus. So if there is cholecystoenteric fistula, then the treatment for that is cholecystectomy, and you will do primary repair of the bowel in the same setting. So you will take down the fistula, cholecystectomy, take down the fistula and repair the duodenum. So this is the treatment for this, as you can say this. If there is gallstone ileus, then treatment is you will do laparotomy, because in this case patient will present with intestinal obstruction. During laparotomy you will do an enterotomy in distal ileum. The site of obstruction is the distal ileum. You will do enterotomy in the distal ileum, not at the site of obstruction. You can say just proximal to obstruction. And you will take out the stone, and in the second stage you will treat the fistula, because in these patients, first stage you will do this thing, in second stage you will treat the fistula, because the patient, when patient comes in the emergency, they are physiologically they are not well preserved, so that time you do the minimum required thing, just this much. In the second stage you can call the patient and treat the fistula. So treatment of gallstone ileus is different from treatment of cholecystoenteric fistula. Coming to question number 21, which of the following liver lesion carry a significant risk of spontaneous rupture? See, it looks like hemangioma. Hemangioma can rupture and can bleed, but that is very rare. Hepatic adenoma has high risk of rupture. It has high risk of, there is spontaneous bleeding can occur in this adenoma. So adenoma is our answer. High risk of spontaneous rupture is seen in adenoma. This is, we can say, 10 times more common in females as compared to males. OCP intake has a significant risk factor. And important part about adenoma is this is pre-malignant. This can lead to hepatocellular carcinoma. That's why in case of adenoma, most of these, they require surgical excision. Surgical excision is the treatment for most of the hepatic adenoma, which is not required in other benign tumors like focal nodular hyperplasia and hemangioma. Most of times in hemangioma and focal nodular hyperplasia, observation is done. But in case of adenoma, especially if it is more than 5 centimeter, you need to remove because this is pre-malignant. To question number 22, patient comes to the emergency department with history of left lower quadrant pain, febrile, WBCs are raised, diverticular and gross intra-abdominal free fluid, and there is feculent material intra-abdominally. What is the Hinchey stage? See, this Hinchey classification is given for perforated colonic diverticula. Hinchey class 1 is initially when there is the perforation is small, there can be limited pericolic abscess. Pericolic abscess, or you can say mesenteric abscess. In stage 2, there can be localized pelvic abscess, localized pelvic collection or abscess. There will be pus, but mainly it is present in the pelvis. In Hinchey's class 3, there can be generalized purulent peritonitis, pus in the peritoneal cavity. And Hinchey's class 4, there will be generalized feculent peritonitis. There will be fecal material in the peritoneal cavity, which is given here feculent material intra-abdominally. So this will be Hinchey's stage 4. So in this question, answer is stage 4 Hinchey's. The triangle of pain is bordered by all of the following except. See, this triangle of pain and triangle of doom, these are for laparoscopic hernia repair. Laparoscopic hernia repair, the anatomy is slightly different from the anterior approach, because suppose this is deep inguinal ring and this you are looking intra-abdominally. This is vas, this is gonadal vessel, and this is peritoneal reflection. This triangle is known as triangle of doom. This is triangle of doom. Importance of triangle of doom is external iliac vessels. External iliac vessels run in this triangle, so any injury can lead to severe bleeding. So that is the importance of triangle of doom. Another triangle is there. This is iliopubic tract, and this is peritoneal reflection again. Peritoneal reflection. This is known as triangle of pain. This is called as triangle of pain because in this triangle many important nerves are there. These nerves like lateral cutaneous nerve of thigh, femoral branch of genitofemoral nerve. So these nerves are there. Importance is when you do the inguinal hernia surgery laparoscopically, again you have to put a mesh. So when you put a mesh, suppose this is mesh, you have to fix the mesh by placing some trackers. So trackers are the small staplers like thing. They will keep the mesh in its place. So importance of this triangle of pain is you should not fire the tracker in this triangle, because if your tracker goes and hit a nerve, it will cause significant pain in the post-op period. So that is the importance. You should not fire your trackers in this. So if you see the triangle of pain, it is bounded by gonadal vessel medially, peritoneal reflection laterally, and iliopubic tract superiorly. Ductus deferens is not a part of triangle of pain. It is a part of, we can say, triangle of doom. Coming to next question. Supplementation of which of the following micronutrients improves wound healing in patients without micronutrient deficiency? See, this is important. Without micronutrient deficiency. If you see all of these vitamins and these nutrients, vitamin C, A, selenium, zinc, they all are required for wound healing, but not in supraphysiological dose, or we can say extra physiological dose. So if patient does not have vitamin C deficiency, vitamin C is not going to help much. If patient does not have selenium deficiency, it is not beneficial. Does not have zinc deficiency, it is not beneficial. But vitamin A is beneficial even in we can say supraphysiological dose, supraphysiological quantity. So except vitamin A, see, all these are required for wound healing, but only if there is deficiency of these vitamin C, selenium or zinc, they will help. But vitamin A will help even if vitamin A levels are normal. This has a beneficial role. So our answer here is vitamin A. Coming to question 25. During emergency appendectomy, there is a needle injury with spontaneous bleeding, which of the following is the most likely to be transmitted if the patient is infected with all of them? See, HIV, the transmission rate is 0.3%. This we are talking about the needle injury. Hepatitis B, it is 3%. And hepatitis C, it is 30%. So you can see hepatitis C has the maximum risk of transmission during a hollow needle injury. So hollow needle injury, the chances of transmission is more as compared to solid injury, solid needle injury. So out of, if the patient is infected with all, the maximum chances are there in the hepatitis C virus infection. So thank you. These are the questions of CBT surgery.